This week's presenter, we are going to be the case that is going to be presented for this grand round is going to be by Dr. Dhania. Dr. Dhania did his MBBS and DLO from Calicut Medical College. She completed a DNB from Medical Trust Cochin. Currently working as a senior consultant at Rajgiri Hospital Cochin. She has been the ex-secretary and ex-vice president of the Association of Otolaryngologists of India, Cochin branch. She is the recipient of Krishna Das Memorial Gold Medal for Best PG Paper Presentation. I welcome Dr. Dhania to this presentation.
Thank you,
for this particular grand rounds. In addition to Dr. Dhania, we also have an eminent group of panelists from across the globe today. Okay, so I will be introducing them. So we have, can you see my screen? I hope you are able to see my screen.
Yes, sir.
Yeah.
You can see your screen.
Okay. So we have Dr.
No.
Ioana Alexandra Oda from Bucharest, Romania. She is a ENT consultant. In fact, she is the lead consultant and director of Clinica Nova Exploratory ORL, Bucharest, Romania. Okay. So she has completed her UMF Carol Davila, Bucharest, Romania. She's an ENT specialist. Okay. And she has also done her doctorate, okay, PhD in the treatment of the rupture of tympanic membrane. Okay. University of Medicine and Pharmacy, IAC, Romania. Okay, DIU Inter-Universitary Diploma, Vestibular Pathology and Vestibular Rehabilitation, University of Medicine and Pharmacy, Pierre and Marie Curie, Paris, France. That was in June 2015. And she's been an ENT consultant at University of Medicine and Pharmacy, Grigori T. Popa, IAC, Bucharest. So I welcome Dr. Ioana Oda for this evening's panel. Then
Thank you. Thank you.
I also welcome Dr. Ramesh Rohiwal. Okay, sir did his MBBS and MS ENT from BJ Medical College, Pune, Maharashtra in 1983. He is the director and senior consultant of ENT, Vertigo, and consultant ENT hospital since 1984. Vertigo Clinic 2003, Aurangabad, Maharashtra. He's been ex-associate professor, MGM Medical College, Aurangabad, honorary senior consultant at Seth Nandlal Dhuth Hospital, Aurangabad, United GIIGMA Group of Hospitals, Aurangabad. He's a visiting consultant, Vertigo Clinic, Columbia Asia Hospital, Pune. He has multiple publications, okay, including a case report in a British Journal of in JLO actually. He's presented papers at various state conferences. He's given multiple orations that I know. Okay. And presented and conducted Vertigo updates and workshops and conferences at state and national level. He's been a guest faculty at BalanceCon, Bangalore, GidiCon, Patna, Bihar, Equilibria, Morbi, Gujarat. He's the founder president of AOI Aurangabad branch. In fact, he won the Best President Award a few years ago of the IMA. Okay, and he was the past president of IMA Aurangabad branch, awarded Best President Award at both state and national IMA conferences. Then we also have with me Dr. Avinash Bijlani. He's a neurologist and an ENT surgeon practicing in Delhi. He is just with me here, so it's my privilege to have him here. Okay. He is the director of Madhav Medical Center for ENT and Vertigo and senior visiting consultant with DHLI Super Specialty Hospital. Presently, I am sitting at Madhav Medical Center. He has a long-standing experience in dealing with vertigo patients and is well-versed with positional tests and maneuvers for BPPV. His center is equipped with the VNG system and other modalities for diagnosis of vertigo. He's also developed a low-cost model depicting 3 semicircular canals for better understanding of the mechanics of otoconial debris in BPPV. He presented this model for the first time in BalanceCon 1 that was held in Bangalore in 2017 and elaborated on its use in NES Jodhpur in 2018. Okay, it received wide press coverage in Dainik Bhaskar newspaper in Jodhpur. He holds the honor of having been invited to the national and international conferences. He's a past president of IMA Karol Bagh branch and also past governing body member of NES of India. He has been a governing body member of AOI Delhi chapter for many years till date. he has to his credit papers published, presented on topics like vestibular migraine, vestibular paroxysmia, and BPPV. He was a senior consultant with Fortis Hospital, Karol Bagh, New Delhi. He is also visiting consultant at BLK Hospital. What is not written here is he has been invited to give the Neurotology and Equilibriometric Society of India oration just a week ago. So he has given the NES oration just a week ago. So so we have this eminent panelist. I again welcome Dr. Voda Yana Yoda, Dr. Rohiwal, and Dr. Avinash Bijlani again. Now I request, with these introductions, I request Dr. Dhania to make her presentation. Ma'am, over to you. So just before the presentation, I will explain the format of the Vertigo Grand Rounds is this. This is fixed date. We always do it in the last Friday of Friday of every month. 8:30 p.m. is the fixed time. The format is that one consultant is going to present a case, then that is going to be followed. That is going to be followed by a brief introduction, background information containing introduction from me, and then after that we'll have eminent panelists who will be answering questions that are asked by the consultant who is presenting the paper, presenting the case report. So with that, I hand over the stage to Dr. Dhania. Dr. Dhania, you can start sharing and present your paper.
Good evening, all. At the outset, I would like to express my sincere gratitude to Srinivas sir, my mentor in Vertigo, and the team Cyclops. It is my pleasure to present this case in front of this eminent panelists, Voda madam, Ramesh sir, and Avinash sir, and all the wonderful audience. So let's see therapeutic options to soothe a vertiginous catastrophe. So the whole story, I cannot proceed, sir. Can I check it again? I cannot go to the next slide.
Hello.
Let me check.
You can click on the arrow button.
You can just click on it.
So the whole story starts with a 70-year-old male patient. He came to our hospital, Rajagiri, to meet my colleague and head of department, Dr. Rajesh Raju George, for labyrinthectomy. He was referred from outside for the same. My colleague, after hearing the patient, felt that at that point of time, labyrinthectomy may not be of benefit to him, and he referred the patient to me for vertigo evaluation. So he was having distressing vertigo for the last 4 years. So for 4 years, he was visiting multiple hospitals. Since 2014, he was having right-sided ear block and tinnitus without symptoms of vertigo. Initially, this ear block used to get relieved and become normal. But by 2018, the right-sided ear block progressed to severe sensorineural hearing loss, right side. Since 2014, he was having recurrent phonophobia and photophobia. He describes that whenever some utensil fall in the kitchen, he gets irritated and agitated. So let's see the evolution of vertigo. Since 2018, he was having recurrent episodes of external vertigo, each episode lasting around 2 minutes. It was triggered by change in position of head. It was associated with vomiting. Sometimes its vertigo was precipitated by long distance travel, stress, etc. He never had an episode of headache. He never gave a history of problematic headache or heaviness of head. Now coming to the progression of symptoms, initially the vertigo was once in 2 to 3 months. Later on, the frequency slowly increased to up to twice a week. The severity of vertigo increased to around 1 hour. Later, he became almost bedridden and he went into depression. When he came to us, he was in depression. So he shared these PT reports with us. In 2014, he had mild sensorineural hearing loss in right ear. In 2015, the pure tone average has become 31. Then again in 2016 it has improved. It has become minimal. It became minimal hearing loss. So initial period he was showing fluctuant hearing loss. Later on, by 2018, the right ear hearing loss has become moderately severe sensory neural hearing loss. And by the time he reached our hospital, he was having severe low frequency sensory neural hearing loss in right ear. So the last 4 years, what he did, for 1 year, he was improving with corrective maneuver and vertigo. So initially his vertigo was improving with bed rest for around 1 to 2 hours. And for 2 years, he was taking vertin 48 milligram twice daily. So at the end, there was no improvement. For the last 1 year, he has no improvement with vertin or any corrective maneuvers. He was diagnosed from outside as Meniere's disease, and he came to a hospital for labyrinthectomy. So other comorbidities are he is diabetic for the last 20 years. He had angioplasty in 2003 and 2016. He had radiofrequency ablation for supraventricular tachycardia in 2017. So at the time of presentation, he had recurrent external vertigo lasting around 1 minute, precipitated by change of head position. Severe external vertigo recurrent episodes lasting around 3 hours, triggered by long distance travel, and there was occasional unsteadiness. So let's see how we proceeded. I admitted the patient, stopped vertin. So on the first day, did a position test with Frenzel. It was positive for right horizontal canal BPV apogee type. Right barbecue roll was done. So next day when I met the patient, he was a bit comfortable. So just repeated the position test with Frenzel to see the response. It was showing left horizontal canal BPPV apogee type. Left barbecue roll was done. And next day when I met the patient, he was very much comfortable. So other findings which we noticed was if my MRI brain was normal, MR angiography was showing tortuous left vertebral artery. After 2 rolls, the patient was a bit comfortable. So I did not want to do a full VNG and disturb him. But out of my curiosity, checked the test which was not causing much difficulty for him. So it was showing normal saccades and normal smooth pursuit. In center gaze without fixation, there was left beating nystagmus. So I sat with the patient for about half to 1 hour, talked with the patient, explained the nature of the disease. He was reassured. Topiramate 25 milligram was started. Vitamin D was supplemented. Actually, this vitamin D assay, which the report which came after, was within normal limits. So the response, he's on follow-up. For the last 3 months, he never had a single episode of vertigo. He's doing all the routine activities, including driving. Now he's coming to a hospital, driving the car by his own. He's very happy now with no depression. So now here the points to ponder are how the 4-year distressing vertigo was completely relieved for the last 3 months. How topiramate helped here when vertin started showing no response. How the recurrent secondary BPPV suddenly stopped. Is it because we regained the confidence of the patient, and is that which brought the patient back to normal? Now coming to vestibular migraine, Meniere's overlap. Treating migraine, is it because we treated the migraine and it cured the Meniere's overlap? Secondary BPPV, is it controlled with anti-migraine therapy or vitamin D? Is it because it's a channelopathy and now it has started responding to a different class of medication? Is it the reassurance and understanding the patient's disease, which is curing the patient and benefiting the patient at this moment? So Jos was very happy when he left the hospital, and he shared a video with us in Malayalam. I told him that I am going to present his case in a forum of doctors. The majority does not know Malayalam. So he shared me this video in English.
Good morning. I am Joseph Abraham, age 70. For the past 20 years, I have been diabetic with history of coronary artery disease. In 2014, hearing started deteriorating in right ear, starting with annoying sounds which the doctors call tinnitus. I was consulting many ENT specialists, but by 2018, it progressed to complete hearing loss in the right ear. By the end of 2018, the occurrence of vertigo started. Unanticipated events of spinning sensation back to a few days interval, which lasted for an hour or so, followed by vomiting, left me devastated. I used to get better by taking bed rest for 1 or 2 hours. First, I met many neurologists who all ruled out a neurological problem after MRI. I continued to have frequent attacks of vertigo and I started consulting ENT specialists in different hospitals in Kerala. Some tried to correcting procedures and prescribed me Vertin tablets. Though different diagnosis names like positional vertigo and Meniere's disease were mentioned, I had no definite idea what was happening and I was in the verge of depression. I had no relief. But the end of 2019, the neurologist I met directed me to the neurologist. After examination and correction procedure, he also advised me to take Vertin 48 morning and evening for 1 year. The 1 year with Vertin 48 morning and evening gave me almost complete relief without any vertigo episodes. Later, after consulting the neurologist, the Vertin dose was tapered and slowly stopped in January 2021. After about 2 months, the vertigo again started. Again, after consulting the neurologist and examination, he diagnosed my illness as Meniere's disease and advised me to restart Vertin 48 morning and evening again. But this time the vertigo didn't subside and was increasing daily. Fed up with the almost bedridden condition, I started searching for what next. My frantic research gave me information about labyrinthectomy surgery as a cure for Meniere's disease, which was supported by a few ENT doctors also. My next search was for a place where the surgery was done. As this was not a common surgery, and it was thus I approached Dr. Rajesh Taju George at Rajagiri Hospital. Hearing all my illness in detail, he said he can definitely do the surgery, but it may not be the correct solution at present, as the disease itself may not be pure Meniere's disease. And he asked me to wait 2 months for the Rajagiri ENT team to investigate before considering surgery. After internal discussions, he referred me to Dr. Tanya E.K., vertigo specialist and a team member of neurology in Rajagiri Hospital. Dr. Tanya did a detailed study of my illness and went through all records. Later at hospital, she stopped the Vertin dose for further investigation. She explained to me in detail the causes and variants of Meniere's disease. Based on this, I realized that my past 4 years consultations and medications focused on inner ear disorder, like Meniere's disease, may not be the only reason for my symptoms. Further to the investigations and discontinuation of Vertin, Dr. Tanya did several evaluations at Rajagiri Vertigo Clinic and finally the diagnosis. I got discharged from the hospital after 40 days of close observation. The last 3 months, I have returned to everyday normal life with only topiramate 25 mg in the morning and no Vertin. Over the previous 3 months, I had no episode of vertigo. It is with utmost happiness and gratitude that I am giving my testimony. I was depressed and almost bedridden when I came to Rajagiri, but time and effort to hear me and my problems with empathy itself was a great relief to me. Here, now, I am back to my normal activities and happy. Thanks to Dr. Tanya E.K., Dr. Rajesh Raju, Vertigo team.
So I like anyway the Jaws is back to normal. So why the 4-year distressing vertigo is completely relieved? I would like to know the opinion of the expert panel. So Jaws is also awaiting for like
Yes,
today
ma'am.
he knows that his case is being discussed.
Absolutely. So thank you for sharing that wonderful story of joy of the patient after so many days with one topiramate. So before I take up the questions to the panel, I'll just make a few slides presentation so that there is some background context. And then after that, we will take all your questions. Again, you'll come back and one after the other, you'll ask questions and then we have the panelists answering them. Okay. And then giving their perspective also. Okay, ma'am?
Yes, sir.
So I think you can stop presenting so that I can share. Yeah. I'm sharing my screen. Okay. So there are few points before we actually go ahead with the discussion. As usual, this is the format that we do. Okay. Fine. So I want to bring everybody's attention to this one particular paper. Okay, this one particular paper which came in 1980s by the great Miller Fisher. Okay, so the late life migraine accompaniments as a cause of unexplained transient ischemic attacks. Okay, this was a very beautiful paper which came in 1980. Now what happened is a few years later he made one more. Okay, a few more patients. Okay, so in 1980 Dr. Miller Fisher presented, the neurologist, 120 patients. Then then afterwards, a few years later, he added a further 85 cases of late life migraine accompaniments to his, and then published it again. Okay. So in that, the main criteria for diagnosis of late life migraine accompaniments he gave as scintillations or other visual display in that particular spell. Next in order is paresthesia, aphasia, dysarthria, paralysis, these things. Build-up of scintillations, which is not seen in cerebrovascular disease. March of paresthesias, this does not occur in cerebrovascular disease. Then progression from one accompaniment to another, often with a delay, means one kind of symptom comes and then I'll tell what are all those accompaniments in the next few slides. The occurrence of 2 or more similar spells, headache during the spell, episode lasts 15 to 25 minutes. This is a very important point because in TIAs, the episodes last less than 15 minutes. Okay. Characteristic midlife flurry of migrainous accompaniments, multiple accompaniments. Okay. That is a generally benign course, normal angiography, including which excludes thrombosis and exclusion of cerebral thrombosis, embolism, dissection, epilepsy. Okay. Thrombocythemia, polycythemia, and thrombocytopenia. The classifications that he gave of all the 120 patients in his first series was, some of them were visual and paresthesias, visual and sleep disturbance, visual and brainstem symptoms, visual paresthesia, sleep disturbance, speech disturbance. Okay, visual paresthesia, speech disturbance and paresis, non-visual accompaniments only, recurrence of old stroke deficit and miscellaneous. Okay. The accompaniments, these are the clinical patterns. Okay, the actual accompaniments which he actually mentioned in the 2 series are, okay, scotomas, paresthesias, aphasia, dysarthria, hemiplegia. He simply says brainstem symptoms. Okay, does not mention whether it is vertigo or anything else. Blindness, blurring of vision, hemianopia, monocular blindness, ophthalmoplegia, oculosympathetic palsy, mydriasis, confusion, stupor, cyclical vomiting, seizures, diplopia, deafness, recurrence of old stroke deficit, chorea. But what is clearly missing here is vertigo, but still this paper makes a lot of sense because he makes a beautiful case of migraine being the cause of the TIAs. Okay, the cause of the transient ischemic attacks is what he makes a beautiful case. And then in this particular paper, he makes another beautiful case where it tells 90% of transient ischemic attacks of the posterior circulation are less than 15 minutes duration. So therefore, he says anything above 15, here it is 15 to 25 minutes duration. So these things are point towards an etiology other than TIA rather than actual TIA. Okay. Then the other thing in your patient that we saw is a tortuous vertebral artery. So I thought that also some background will be needed before we take the discussion forward. So high resolution computed tomography of the basilar artery. Okay. This particular seminal paper again came from smoke. Okay. From Smoker and et al. And till today, this is the standard criteria for this is the one that gives the radiological criteria for classification and grading of the vertebrobasilar dolichoctasia. Basically, dolichoctasia is where the vertebral artery is ectatic, means it is bigger than normal vertebral and basilar artery, and dolicho means it is elongated and it is tortuous. Because it is elongated, it becomes tortuous. And there they again go on to tell a dolichoectatic blood vessel how in different patients. Okay, this is again a beautiful paper. I suggest that all of us can do a reading. Okay, where different kinds of waviness, okay, and elongation can cause different kinds of symptoms. Like here, the pressing of the sixth nerve, pressing of the third nerve, like that, and causing different kinds of symptoms. Multiple clinical case presentations are included in this paper by Smoker and et al. So you can see again third nerve stretch, okay, multiple lower cranial nerves also, everything is covered in this particular paper. I thought this is going to be a good background because we all know that migraine changes. Migraine is known for metamorphosis. Migraine that comes as headache in early life will change to more of a vertigo, more of a brainstem-like symptoms, these things as somebody ages. So what is it that happens in these particular people that causes this change in the phenotype of the migraine? What is the underlying structural change that could be happening? Is it vascular that is causing? Is it the vascular change that is making them less prone to headaches and more prone to symptoms that are attributable to ischemia? Okay, more prone to symptoms that are attributable to ischemia. We do know that migraines are known to even cause strokes also. So this is the background that I wanted to present before we actually take up the discussion of this particular patient who appears to have responded to topiramate, which is a drug that we give for migraine, and who did not respond to so many other medications, to the extent that he was actually thought of for surgery to actually ablate his labyrinth, surgical ablation of the labyrinth. But then luckily, okay, so far we believe that he's got a relief with the anti-migraine medicine. So with that, I stop my presentation and I will call on the panel. There is no presentation now, so I'll call on the panelists to come forward and initial comments. So may I ask Dr. Ramesh Rohiwal, followed by Dr. Voda, Yana Voda, and Dr. Bijlani to make their initial comments about this patient before we actually take up one question after the other. Is Rohiwal? Yes, Dr. Ramesh Rohiwal.
As it has been established that the patient had a fluctuant hearing loss and had vertigo and was getting good relief with Vertin and all. It was a case of menial disease, you can say, to begin with. But again, few points which are definitely important, that there is no relief in between, and he had again apogeotropic vertigo, apogeotropic nystagmus in recent episodes. So what I feel the hearing loss which the fellow has can be attributed to his diabetic problem that he has got for last 20 years. Again, tinnitus is known in the patients of cardiac patients, those who are taking aspirin for a longer length of time. So these 2 points also, they need to be considered. That's what I feel.
Yes, sir. So one thing that is like we should keep in mind that aspirin could itself be one of the causes. Long-standing diabetes could have actually predisposed to some of his hearing loss, is the point that Dr. Ramesh Rohiwal is making. Thank you, sir. Dr. Yana Voda.
Hello, very interesting case. what can I say? We know that the endolymphatic eye drops symptoms are also in Meniere disease and in migraines. And this phonophobia and this photophobia, the vomiting, the stress, the depression, the optocinetic stimulation, and the long distance travel. Also, these are some clues for migraine. And for me, most important is that 2 years or Verdi beta-histine don't work at the big doses. That means that maybe, not maybe, for sure now, it was not Meniere disease pathology. What to say? Also, Meniere disease have at the beginning hyperexcitability. We know that migraine is a disease, vestibular migraine is a disease with hyperexcitability. So I know that at the video head impulse test, in both pathology, you can have a normal test. Also, calorics can be normal in Meniere or in migraine, depends on the stage. For me, you know that I like very much step test, rotatory step test. And it's very easy because we don't use the automatical chair all the time, the manual chair. And for migraine, we found very usually hyperexcitability. So we can use this test also for a tinnitus. If we begin to investigate a tinnitus and earfulness with these tests, we can find these hyperexcitabilities. So what to say, if it's not working with diuretics and with beta-histine, it's better not to expect 2 years to try to find a good resolution. We can try this topiramate quickly, and we can have very good results, like Professor Dr. Diana had. That was very good idea.
Yes.
Thank you.
So some of the points, just to reiterate what Dr. Voda was telling is, one was non-responsiveness to Meniere's directed medication. The next one is that there are some investigations like video head impulse test and caloric test, which can turn out to be normal even in clear-cut Meniere's disease and also in migraine. Specifically in migraine, she is sharing her experience of a step rotatory test in a chair, which need not always be an automatic chair. It can be a simple chair in which you can rotate the person and see the nystagmic response. And in migraines, she has shared her experience of seeing hyperexcitability in that particular thing. And then, so hyperexcitability is the feature of migraine in a lot of sensory systems, not just one. And the other way in which we can be testing is the audiological tests for hyperexcitability. I mean, or recruitment, these kind of tests, maybe short increment sensitivity index, these kind of things. Okay, so coming to, and of course, this is magic pill that Dr. Dhanya is presenting to us, that she found the topiramate to be helpful in this particular patient, and that we are all glad. So now, thank you, ma'am. Now may I request Dr. Avinash Bijlani, who is just sitting next to me, to add, to give his comments.
Well, a very interesting case, rather very intriguing. And well, let me put it this way. The patient did have photophobia and phonophobia, but typical history of past or present headaches is typically missing. Now, you know, when you're taking the history from a 70-year-old man, and if he used to have headaches at the age of 25, he might just be amnestic towards it. He just might have forgotten about it, not even thinking. So possibly, maybe if you again go and probe the patient or try to ask his wife or somebody, did he suffer from headaches? That might come out in the history. One, if you're thinking in terms of migraine.
Can I
Response to
interfere, sir? Because
non-response to beta-histine is not very surprising for me, because there are many schools of thought still going on whether beta-histine works in manias or not. Maybe it does not work in quite a large number of patients also. And those patients have to be tried upon with diuretics and all. And there are certain countries where in fact beta-histine is not in use at all for that matter. So that's a separate issue altogether. The audiogram, present day audiogram, is quite compatible with the diagnosis of manias. When you look at the audiogram on the right here. 1. 2. Now, coming to the response with topiramate. See, topiramate does not only enhance the GABA activity and reduce the glutamate activity, it also works as an anti-epileptic by working against, by blocking the sodium channels, right? So it's basically an anti-epileptic drug. Now, these kind of, when carbamazepine can work and oxcarbazepine can work for vestibular paroxysmia, and there's a neurovascular cross compression. Now, was a cis sequence done in this patient? 1, are we missing out on a neurovascular cross compression? Because the neurovascular cross compression could possibly explain all the things. Hearing loss, it could explain the spells of vertigo, it could even explain the positional vertigo. And you see, this patient has an aberrant tortuous vertebral artery. Now, are we talking in terms of the compression of the 8 now somewhere around the corner? So these are the things that really come to my mind.
Okay. So as summarized by Dr. Avinash Bijlani, he's placing a high emphasis on the state of the blood vessel and whether it is actually causing any compression. And as Dr. Dhania has pointed out in the scanning, that there has been a dolichoectatic vertebral artery. And of course, though we have not really clearly pinpointed whether it is actually pressing on any particular blood vessel. That is one thing. And then the other thing is, whenever there is a dolichoectatic blood vessel, posterior circulation, there are some hemodynamic alterations. There are 2 things that happen. One is the pressure change that happens. There is the hemodynamic alterations that happen because of dolichoectasia. One of the hemodynamic alterations that is known is a chronic hypoperfusion in the posterior circulation areas. Okay, so chronic hypoperfusion or TIS, both of them are known. Okay, mean transient hypoperfusions or chronic hypoperfusions, both of them are known in cases of the dolichoectatic blood vessels in the posterior circulation. So that means that all of these things. And then how a migraine medicine actually ended up giving is the relief. Was it actually the migraine it controlled? Was it the response that used to happen because of hypoperfusions that it worked? It is open for discussion. So now so after the initial comments, I would want Dr. Dhania to take her questions one after the other. Please ask, ma'am. If which of the questions are not answered, you can just again re-ask. But I think before that, I see Dr. Yana Voda raising her hand. I think she wants to say something, ma'am. You want to say something?
Only that I remember that the dolichoectasia of vertebral artery was in left side and the pathology of this patient was in right side. Doesn't matter or doesn't matter the side? Because also I try to find that I work a lot with recurrent VPPP to try to find if it's matter the side of the tortuous.
Okay, on the tortuous side. Okay. And other thing is the tortuosity, it will be sometimes so tortuous, the right wing will go to the left and it will come like this. Okay, that is also there. Okay, so tortuous it will be. I think Dr. Ramesh Wahiwal wants to say something. Sir,
can it be just an accidental finding of the tortuosity?
An incidental finding. The dolichoectasia can simply be an incidental bystander, which is ending up getting blamed. Yes, possible. Okay. So now there are other questions also. There is Dr. Ankit Patak has some questions. Okay, I think Dr. Dhania, you can also go through that. This thing. Some questions is, why is it not superior canal dehiscence? Okay, is the question. Large AB gap. Okay, long distance travel triggered vertigo. Okay, I don't know whether long distance travel can actually be called as pressure, because the road travel and pressure is not really this thing. Oral fullness and tinnitus. Why don't you think that this is SCD? Is the question that he's asking. Anybody wants to take that question? Why it is not SCD? Why superior canal dehiscence? Why it is not superior canal dehiscence? So airborne gap that he is pointing out may simply be a shadow curve. Maybe it is SNHL on this side. Dr. Dhania?
Sir, there was a fluctuating hearing loss, no? In 2014, like
there was
all
a
the
fluctuating area. Was there airborne gap? I didn't.
Initially, I don't think there was an airborne gap.
Initially, it was not. Initially, there was no airborne gap. But
Okay.
the latest audiogram is showing airborne gap.
Yeah. Maybe that was just a shadow curve, the other ear responding for the bone.
Also possible.
Okay, maybe we can review that audiogram again. That is
The only thing that goes in not in favor of superior semicircular canal dehiscence is it doesn't have other symptoms those which will suggest of the particular entity. And
okay.
CT scan or MRI finding they are not supporting that particular diagnosis.
Okay, was a CT scan done? Was a HRCT done?
No, sir, only MRI was done.
Okay, MRI was done. Maybe. See, what happens is, okay, we don't consider canal dehiscence. Probably one more thing is like the duration. This long attacks of vertigo, we don't come across usually in superior semicircular canal dehiscence. They are more of short spells that we come across. Okay, so that is one thing. And even the pressure symptoms are immediately triggered pressure symptoms. Okay, so it is like if you apply a pressure now, that is the time at which these symptoms come. Okay, in superior canal dehiscence, it is not that you apply pressure for some time and then after that it is. If there is a pressure change for some time and after that the symptoms are triggered, that goes more in favor of migraines actually, rather than a superior canal dehiscence. Okay, so that I think I am okay. Is I'm not sure whether is Dr. Ankit there? Dr. Ankit, your question partially at least answered?
Yeah, sir, answered. Thank you so much for answering.
Thank you. Okay, and Dr. Sunil Matthews is asking, is there any reason to start therapy with topiramate and why not flunarizine is the question. Why not flunarizine is the question. Dr. Bisla, you want to take it?
Topiramate has a carbonic anhydrase inhibitory action, right? When we read the functions of topiramate,
yeah,
it has a carbonic anhydrase inhibitory action, just like Diamox.
That is there, but then why not flunarizine is the question. That's why not flunarizine? The answer to the why not flunarizine is a very good drug for a therapeutic trial. Flunarizine is a wonderful drug for short bursts, 5 days, 10 days, 15 days, even 1 month. But it is a very, very dirty drug for the long term. I have personally seen patients developing Parkinsonian features after flunarizine for long term. So flunarizine is a dirty drug for long term. Flunarizine is a wonderful drug for short spells, and especially when you want to give a therapeutic trial and take a response. Okay, it's a very beautiful drug. If you want to give 10 days trial or 1 month trial, just to make sure that establish that it is actually vestibular migraine, flunarizine is beautiful. But long term, it's a dirty drug. In the sense it actually causes a lot of problems. It causes weight gain, it causes slowing to the extent that you actually start seeing that the patient start showing up like Parkinsonian. So I have come across them. So maybe that is one reason. And in an elderly person, maybe that is not a that is something to be avoided. Maybe that is one more reason. And maybe we have started looking at some other medicines for migraine which are benefiting, especially in the elderly. Topiramate may be a better choice. Then there are other medicines also which we are coming across now. Our options have increased actually. In fact, I know Dr. Dhania has actually started giving even, I think you are also giving sodium valproate for migraine. Is that
Yes,
right, Dr. Dhania?
Yes,
Okay.
one of
Yeah, one of our patients is actually getting sodium valproate and actually started responding. Okay, so our options are bigger now. Okay, our options are huge. Okay, which is a good thing. Okay, ma'am, I think you had some more questions. Dr. Dhanya, I think you had some more questions.
No, Avinash sir was telling about migraine. No, I had the similar doubt whether I missed it. So I just called him again and I was asking it, poking him whether he had any headache. Like you, so now he's a bit educated. So you told me firmly that I never had headache. So the same doubt had come to my mind also, whether I'm missing it.
Actually, what happens is, as Dr. Vijnani pointed out, I had a patient who used to have falls, who used to actually have falls. And then I asked him questions like, did you used to have headaches in your younger days? He tells, no, I never had headaches. And then ultimately, he tells me something. He tells that after I had the fall, I start yawning. That thing. He tells I start getting yawning. And then I asked him, okay, then why did you tell this about yawning? Then he tells me, in the younger days, when he was recently married and those days, whenever he yawns, his wife tells that you are having a headache, you're yawning. Okay, so that tells that he used to have yawning spells before. So he used to remember them as yawning spells, not as headache spells. So these things happen. We have had patients. I have had a patient in whom I had done a nasal, surgery for polyposis. I had done an endoscopic surgery for polyposis. And I remember particularly, because I'm very particular in taking the history of any pre-anesthetic history. I personally take pre-anesthetic history, not just the anesthetist. And I know of these particular patients. And I used to asked her, do you have any reactive airways, any asthma, any breathing problems? She says, no. Anesthetist asked, junior anesthetist, everybody has asked her. I know that because, and then after the surgery, she goes into after she comes into the recovery room, goes into severe bronchospasm. Okay, and then of course we rescue her and all that. Fine, everything is perfect. Then we go and ask her, you seem to be having a previous history of asthma. We asked, all of us asked, and you never told. And she tells that my doctor told me I'm cured, so I did not mention that. She used to have asthma. She has taken treatment for multiple years. And then she tells the doctor told that I'm cured now. So I told I don't have it. That's all. So how people actually understand our question also is there. So those things are there. So of course we have to, okay. So this person seems to be highly informed and very cooperative in the sense he seems to understand his care process. So when he says no, likely it is not there. But then sometimes they suddenly tell that yes, it was there. So it is always better. Okay, especially because topiramate has worked for him. So probably it was actually migraine before. We don't know. Okay, yes, great. So, ma'am, I think you had some questions. And one more thing, there is a request to just show the audiograms again. Can you just reshare the screen and show the audiograms again? Audiograms again and again, repopulate the question so that again we can start. Because I think there was a digression, we went away. Let us come back to the questions. You can share screen, yeah. I think Dr. Rajshekhar wanted to see the audiograms again. Yeah, Dr. Rajshekhar, I think for you the audiograms are there. There is no airborne gap as such.
Yes, sir. Meditation.
There is no airborne gap. Okay, that is fine. Yes, Dr. Dhanya, I think you stopped sharing again. Can you put the questions?
Yeah. Yes. Actually, I shared the questions in the presentation itself.
Yeah, in the presentation, you can go down to the presentation and ask the questions again.
Yes, sir.
The points to ponder.
Yes, sir. So,
yeah, I think even Dr. Sandeep Sharma is asking for MRI. I think the MRI films are not there, but I think you added the findings that there was a vertebral artery which was tortuous. Okay, so 4-year distress was completely. There is one more question here that is asked. Has the therapist's empathy caused the response? Is the patient actually responding to topiramate or is the patient responding to Dr. Dhanya?
That's a good question.
Dr. Yona, I want your take on this. Have you seen patients actually responding to the carer rather than actually to the drug?
If we are sure, and I am sure that vertigo is a symptom, that means it's a dysfunction, that means should be okay with changing doctors and to empathize with the patient. And if we change attitude and we give good explanation, will be great for the patient. And in this case, these vertigo symptoms, also the tinnitus and everything, shows that from the beginning, the patient had an hyperexcitabilities, but he has also diabetic neuropathies and was a patient with a lot of comorbidities and problems with hearts and drugs and depression. For the depression, I was very happy about his story. Now he's happy. Topiramate, I know that topiramate give depression. I hope will not start it at this patient. What to say? We use in our country a lot of topiramate. We don't have flunarizine, so it works, and it works also in fullness, and we use in fullness and in hard tinnitus. We explain to patient, we try to give you for only 1 month. And in 3-4 weeks can have very good results. So it's important, and I know that Dr. Danaya is a very good doctor and changed the mind and the perspective of this patient, and both are important. Empathy and
both
the
are important. Okay, so they do
sure.
respond to the drug. They do at least partially respond to the carer also. Okay. In fact, the case series that I presented of Dr. Miller Fisher's case series of late life migraine accompaniments. Okay, I think I encourage all of you to actually go through those cases. Okay, those papers are easily available on the net. Okay, so what those late life migraine in those patients, of the multiple case histories are actually written. The actual stories are written in that. There are some people whose things, the symptoms are triggered by sudden changes. Okay, sometimes stress, sometimes just being woken up, suddenly being woken up. And there was one particular patient in whom, when there is a stress, the person feels better. Okay, so like that, these times, the different kinds, but emotion plays a huge role in actually the symptoms. So which has been observed by a lot of people. So that's a big thing. Okay, and then Dr. Saurabh Jain is asking, should we switch to topiramate? I think the question is like, should we make it mainstay of treatment for all the migraine patients? Possibly, I think at least after this session, a lot of people will start considering taking topiramate a little more commonly than we have been doing so far. At least I will do that. Okay. Then Dr. Ramesh Lohiwal has made a very nice point here. I think, sir, you can actually come online and tell. I don't know, maybe the lighting is an issue. Okay, so direction changing nystagmus is very common in vestibular migraine. That is true. So vestibular migraine is one condition where we start seeing different types of nystagmus. Today one nystagmus, tomorrow another nystagmus, day after tomorrow another nystagmus. Different types of nystagmus is known in vestibular migraine. Rajshekar is asking, we should also give a look at geotropic nystagmus other day. That I think that question has been answered by Dr. Ramesh Lohiwal. Okay, so what one day one geotropic, another day geotropic, like that. Okay, so what dose of topiramate to be used? Okay, Dr. Dhanya, what dose are you using right now, and what is the maximum you have reached?
25 milligram once daily. I started with 25 milligram half. Once when you are comfortable, then it may make 25 is the lowest dose, right? Only one.
Okay, so 12. Dr. Ramesh Lohiwal used 12.5 milligrams. You are giving 25 milligrams now. Okay. Anybody has gone to 50 or 100, Dr. Yana?
We start with 25. Depends of the weight of the patient. But for 70 kilos of patient, normal patient, we start with 25. But we explain the side effects that can have. And we wait near 3-4 weeks. And if it's necessarily, I speak about vestibular migraine with a big headache. And we can give also 50 milligrams.
Okay.
Another
And
patient.
how frequently do you monitor?
50 milligrams for 1 month, and we decreased another month with 25 again.
Okay. And then how frequently do you check the eye pressures for glaucoma?
We ask to check before we start. We ask
Okay.
ophthalmological
Okay.
exam.
Fine.
And also for kidney.
Okay. For renal
Creatinine.
function.
Yes, yes.
Great. Dr. Datta has raised his hand. Dr. Datta, yes, sir. I think you have something to share.
Yeah, I think the excellent case. Only thing is the 25 milligram once a day is a very small dose. As a neurologist, we start with 25 milligram, and in migraine, refractory migraine, especially, we go up to 50 milligram twice a day maximum, not beyond it, which we use in patients with epilepsy. We go beyond 100 milligram. But in migraine, we go up to 50 milligram twice a day maximum. But 25 is a very small dose, and lucky that the patient has responded to such a small dose. Second thing is, we get the eye testing pressure done at the start, and maybe twice or thrice if the patient complains with headache and blurring of vision, especially blurring of vision. And these are the 2 points which I wanted to make. 25 is a very small dose for a migraine patient to respond.
Yeah. The advantage of having a neurologist is that, see, they will give us a lot of reassurance. ENTs are very scared. We always start with the smaller dose. The neurologist gives us that, okay, gives a benchmark. Now we go ahead. So we are more confident next time to prescribe. Thank you, sir. Thank you for that. So 100. So we can go up to 100.
How long stretch you prescribe, sir? Stretch for how long you prescribe? 6 months, 9 months, or 1 year?
For migraine, the standard treatment is for 6 months and then start tapering. That depends upon, if the patient is a refractory migraine suffering for years together, then 6 months and then try tapering. Like how we increase it 25 milligram to start with and increase it 25 milligram once a week to see the response, and go up to 50, not beyond 50 BD in patients with migraine.
Great. So 6 months.
6 months.
Okay.
6 months.
Yeah. I think there was one more thing that you were telling the other day is about 6, 12. There was a concept, something like 6, 12, something like that. Correct, sir? Say, I mean, 6 weeks, 12 weeks, something like that. I don't know. Okay. Maybe I'll come. Okay. I don't remember it well. I'll come to that. Okay. So thank you, sir. Thank you for coming in and sharing that information. Yeah.
Can I have a question for your very nice neurologist doctor?
Absolutely.
For this case and this age and this amitriptyline, it's same for vestibular migraine. Do you?
Yeah, actually, both these drugs, these topiramate with 60 plus, 70 plus, they known to get these thought blocks. Very common after 70, and amitriptyline, a significant anticholinergic effect. If the patient has prostate, then I would be very skeptical of using amitriptyline in this age group. But anyway, if the patient is not responding, I would definitely explain them, try it. It may not happen with every patient, but I need to really explain it to the patient that if you have an urinary hesitancy and precipitancy, then in that situation, I need to change it. So that is the precaution before I put amitriptyline in this age group. And second thing is topiramate. I need to explain to the patient in this age group that possibility of a thought blocks.
Okay, thank you so much.
Okay, sir, can you just repeat? I could not. Topiramate, what was the problem? I understood that for amitriptyline, there is a problem with anticholinergic side effects, urinary retention, these things. Yeah. Topiramate?
Topiramate can produce thought blocks. Sometimes they get
heart blocks. Yeah. Heart blocks. Okay.
Not heart, sir. Thought blocks.
Thought blocks. Okay.
Thought blocks. What happens is suddenly stops. Something, the lapses of memory happens. And especially patients who are 60, 70 plus. Suddenly they something like an amnesia for a short period of time in between. And that is known to happen with elderly people with topiramate.
Okay.
We need to be careful in elderly people when you are using topiramate.
And sudden bouts of bravery is what you said.
No, not bravery. Thought blocks is memory disturbances with as far as topiramate is considered. Amitriptyline can produce urinary urgency, urinary precipitancy, and urinary problems, anticholinergic activity. That is related to amitriptyline.
Super. Yeah. Thanks, sir. That was wonderful addition. Thank you. Thank you so much. I think Dr. Kavita Krishnan has a question. How is his hearing and tinnitus now? I think Dr. Dhanya, you can answer that. How is his hearing and tinnitus now?
Now he has severe sensory hearing loss. Actually, tinnitus, I think it is not bothering him right now.
It's not bothering him. Okay. So whether it is persisting or not, it's not bothering him. Okay. So great. So I think this was a wonderful discussion. We are reaching 9:30. That was the time that we thought of giving ourselves. Okay. I want today is weekend. Friday weekend should be a weekend. So thank you all for joining. I'm sure today's patient discussion will have changed a lot of perspective for a lot of people. A lot of people will start thinking in terms of migraines and migraine accompaniments in the elderly. So thank you, Dr. Dhanya, for bringing this particular case and bringing your golden hand. Okay, I know with your hand, if you give something, it is responding. That's what I'm telling you. And then we will try to follow. I don't know whether if I had given topiramate, whether that patient could have actually responded. Okay, I don't know. Okay, so it is good. Thank you very much for sharing that beautiful case. I know you have a lot more patients, a lot more different kinds of experiences. Okay, which I am personally aware of. Okay, so that maybe you can send them for publications, or maybe we can actually have them further in other grand rounds and like this. So thank you for bringing that particular case. And I want to thank Dr. Iona Voda. She joined us all the way from Romania. Okay, it's for
I thank you. Thank you and congratulations for the case. Thank you so much and congratulations for the case and for this very nice evening to me. Thank you and night for you. Thank you so much.
Thank you. And it is still evening for them. Okay, she has stopped her practice so that she can join us. So thank you for that, Dr. Iona. Okay.
No problem. And, thank you.
Thank you. And I also thank Dr. Ramesh Rohiwal. Rohiwal, sir, I'm not able to see you. Okay.
Thank you very much.
Yeah. So thank you, sir. Thank you. I see Dr. Datta has raised his hands and Dr. Rajshekhar has again raised his hand. Anything to add?
No,
or it was previously raised?
No, he said it was previously raised.
Okay. Thank you, sir.
Sir, my doubt is now almost all panelists have concluded it is 90%. It might be a vestibular migraine only, right?
See, we can never reach conclusions here. We just keep updating.
Yes. No.
As of now, we consider it as migraine. 3 months later, we may change the opinion.
It is not like this. Okay. Because even the less dosage of topiramate, like Madam is saying, she has given only 12.5 mg only once in a day. That is helping.
No, she's given 25 now.
25 mg, yeah. As per I'm an audiologist, sir. So pharmacology related, I'll be having less exposure. So my only doubt was like topiramate is helping him even in lesser mg. Why to go to higher doses? That is one thing. Secondly, is like my other doubt was
So I think that again we'll start dosage and all. We'll start 1 more hour of discussion now. Okay. Okay. Now it is the time for 30, 60, 90 dose. This is Friday evening. Okay. Fine. So thank you all. Thank you all for joining. And I have Dr. Avinash Bijlani just next to me. So I'm thanking him from here.
It's my good fortune today that I'm sitting right next to you.
Yeah. Okay. So thank you all. Thank you for joining. And I'm sure this case has made all of us more wiser. and keep joining us every last Friday of every month is grand rounds fixed. Okay, so let us make sure that we continue to learn new things. And thank you all for joining. Thank you all for joining. It makes us, when we see a lot of people joining, I want to actually increase the subscription of Zoom from 100 participants to 300. Give me a reason to do that. Okay, it's very great to see, okay, more than 40 people all the time, okay, throughout that was there, okay, who are very much interested, all of you. So thanks for joining, and then give me a reason to enhance this subscription to 300 participants. Thank you all.
Thank you, sir.
So thank you all again.
Thank you very much, sir.
Thank you.